It's, for us in the area of Nice, in the French Riviera, it's, an old problem. And many years ago, more than 25 years ago, we presented at the French National Academy of Surgery our experience in esophageal resection for cancer in 1988. And in 1989, our experience for gastric cancer, and we published it in the Journal of the Academy. So it's one of the main issues of our department. And what we learn about this, it's really the age maybe can be a discriminant factor, but we didn't know exactly which age is the limit. We choose, depending the organ, but it's not really the organ, it's the surgery. If it's a major surgery, we put the cutoff at 70 years. Gastric surgery is 75, but when we made this trial, we found that the cutoff was at 79 years old, so we didn't know exactly what is the limit of the age. The second problem was the preoperative assessment. It's an assessment only by the surgical team, the surgeon and the anesthesiologist, and at this time we had only the American Society of Anesthesiology score and more or less the intuitive assessment. We were convinced that at this time, for selected patients, mortality, morbidity, and survival rates were not different from the younger patients. I don't think this is true, and I'll try to show you it's not true. And that it's because it was, of course, retrospective series, very selected patients, and center experience, or expert centers experience, and it was not the real life. But what we learned is not to perform palliative surgery in the elderly, resectional palliative surgery, and to avoid as much as possible extended resection, and for example, for esophageal resection, no resection for the upper third of the esophagus. What's new since then? Of course, a lot of improvement in surgery, in anesthesia care, in perioperative care, chemotherapy, radiation therapy, the emergence of alternative treatment and endoscopy treatment, essentially, and new strategies, for example, in rectal cancer, and of course, a best supportive care. And we know that now the age limit, it's not a limit, the age is not a limit, and we move from the age limit to the frailty, as Dr. Leishman told you. We have to see that it's really important to take care of this problem because it will be the most important age group we'll have to treat in the future. The incidence and the mortality of cancer are increasing with age, and to date, currently, it's the only cause of death that increase in this age of group. Moreover, if you look at the French population, 15% of the people are more than 60 years old, and in 2060, 1/3 of the French population will be 60 years and over. In 2040, the age group of 65 years will increase up to 60% more people at this age. Moreover, you know that the life expectancy was doubled in 1 century, and for example, a patient aged 75 years old has more than 12 years of expectancy, so we have to take care of him and to give him the best treatment. Anyway, in the elderly, we know that the features, and it's a constant feature, mortality and mobility are increased, the survival rate are decreased, and that makes the limits of the optimal treatment, and for instance, the surgical treatment. We know that digestive malignancy and the surgery of digestive malignancy is the most increased mortality, and if you see here with comparing with breast cancer, endometrial cancer, and kidney cancer, you see that the mortality rate in the elderly patients is much higher. And if you see by the age, the mortality is increased up to 44% for the gastric resection over 90 years old. In this slide, you can see the European experience of the prognosis. It's registries of all the European countries. And you can see that the prognosis of the cancers, the digestive malignancy, is very poor and is divided by 2 when you compare to youngest patients. For the best prognosis, like the colorectal cancer, but also when you see the pancreas cancer, it's divided more than 2 when you compare with younger patients. So you can see that mortality is high, prognosis is poor, and maybe we can try to find out why the prognosis is so poor. First of all, we have more patients operated on an acute basis, and you can see here the Sweden experience. 27% of the patients are operated in emergency. The mortality rate is much higher than the younger patients, and also the prognosis, and especially for the stage 3 patients, it's almost divided by 2. In the United Kingdom, more stoma, less curative surgery, more urgent and emergency surgery, and more postoperative mortality. But when you look at the 70-year patients and more, you can see that the postoperative mortality dropped from 5% to more than 26% if you operated on the patient on emergency surgery. And this rate didn't decrease during the year. So emergency surgery leads to higher mortality. The second problem is that you can see on this data from the French registry that when the cancer-specific assessment for colorectal disease is not achieved, for stage 3 and stage 4 patients, the prognosis is poor. And when you see where are the patients with unknown stage, you can see that the percentage of patients with unknown stage are mainly the oldest patients. And the risk of death is high when you have the unknown stage. So the recommendation, and especially of the International Society of Oncologic Geriatry, is to perform an accurate preoperative staging, and it's very important to improve the prognosis. Moreover, this is maybe one of the most important data. When you compare the patients after the diagnosis or after the operation, you can see that the curves between the young patients and the older patients are similarly the same after the second year. Before, you have a dramatic increase of mortality in the old patients, and especially during the first months. And this is very important, and this has been pointed out by the Netherlands study with really the same curves. And if you exclude the deaths during the first year, you have the same curves after that. So it seems that surgery is an assault and has delayed effects that can cause mortality beyond the scope of surgery. Another problem is that the old patients seems not to benefit from the new improvement. Total mesorectal excision is, to my point of view, one of the most important improvement surgical tools during the 90s for rectal cancer. And you can see that you know that it decreased the local recurrence, but also it improved the 5-year survival, and especially in the young patients. But as you said, all patients are not included in the studies. So we didn't know what happened with the oldest patients. And in the Dutch TMS study, they compared those patients after the study, and you can see that we didn't have any improvement with the implementation of the total mesorectal excision. This is true for colon cancer, rectal cancer. It's true also for gastric cancer, less aggressive neoadjuvant therapy, less aggressive operative resection, more mortality, 30-day and 90 days mortality. And also the survival, you can see the poor prognosis, but when you exclude the non-cancer deaths, the curves are similar. It's the same with the pancreatic cancer. Of course, the mortality is low here, but you can see that it's very, very selected patients, very selected series, and expert centers. Also in the esophageal cancer, the scheme is the same, with an increased mortality and a reduced 5-year survival. So that is the facts, and that is what we can see from the literature. And maybe some of this issue can be predicted and maybe avoided. If you go to PubMed and you subscribe aged and surgery, you will find more than 1,200,000 data, published papers, and it's an amount of published papers very important. And if you build a cloud on this subject, you will find the keywords that is coming out from this cloud, and you can see the words cancer, colon, patient, tumor, surgery, performed, chemotherapy, and this is the main issue. And we know from this data that a patient coming, whatever the reason he's coming to the hospital or to your consultation, he can be suspected by a cancer, and you have to screen him for this particular symptom. And the main objective is to avoid the emergency surgery and to the decrease of his status. And once again, the International Surgical Oncologic, the International Society of Oncologic Geriatry stated that you have to avoid the emergency surgery. You have to screen the patient and to improve any problem, comorbidity, and to bring them to elective surgery. And if they come in emergency, maybe with a stenting, you can bring them to an elective surgery. The second improvement, and we have seen that just before me, the comprehensive geriatric assessment is very important. And we moved from a very simple team with the surgeon and the anesthetist to a multidisciplinary assessment involving many physicians, nutritionians, neurologists, psychiatry, of course, cardiologists, and so on. And many tools are now available to assess the patients: G8, mental status, nutritional assessment, gait test, get up and go test, so many tests. And if you see the surgical literature, you can see the PACE, preoperative assessment in cancer elderly, which is a mix of various validated questionnaires. And you can identify factors significantly associated with general morbidity and postoperative morbidity. But our geriatrician favors the Balducci score. After the comprehensive geriatric assessment, they classify the patient in 3 groups: the fit group, for who we can give the regular treatment; the frail group, which undergo only supportive care; and the main group is vulnerable, with dependence, comorbidities that maybe we can correct. And we have to face this geriatric assessment with the life expectancy of the patients and the cancer prognosis to bring them to an adaptive treatment or maybe a supportive care. Our team in Nice focus their trials on the first 100 days after the comparative geriatric assessment and before the surgery. And last year at the ASCO annual meeting, they presented the predictive factor, 19 in univariate analysis, but in multivariate analysis, they identify 3 predictive factors: the gait speed test, the nutritional status, and the advanced cancer stage. And this year, just last Sunday, they presented with the prospective study with a larger cohort of patients, a clinical score, which identify 6 factors: advantage tumor stage, the gate speed, the nutritional assessment, 2 points, other cancer from breast cancers, and the performance status. And for each of these risk factors, they give points validated by informatics for the model performance. And the maximum score is 9, the minimum is 0. And if the score is 0, there is no death within 100 days. And if it's 9, you have 63% of the patients who will die during the 100 days after the assessment. And it's very important because this predictive score can give you some tools to select the patients. It works with the whole cohort, but it works also with chemotherapy when patient will undergo only chemotherapy, or for colorectal disease when the patient will undergo surgery for colorectal disease. You can see the same curves as for the large studies. Lastly, the problem with the surgery, should it be different, and should patient benefit from improvement, and especially from laparoscopy? We can say that, of course, the laparoscopy, if you can see, the laparoscopy leads to less mortality, so we do not have to deny the patient for laparoscopy only for the age criteria, as some stated before. For rectal cancer, total mesorectal excision has been one of the most important improvements during the 90s, but there is a lot of debate now for the organ preservation for responders after the neoadjuvant therapy. And maybe for elderly patients, this is maybe a way to improve the result. I showed you that for elderly patients, there is no improvement in the 5-year survival. And we have a French trial with, to compare for the good responders, TME and local transanal excision. To date, we know that we have organ preservation, and we will have the result, the final result, very soon, and I'm sure it will be favoring the local transanal excision for good responders. And this is a trial from the memorial. The wait-and-see approach, as advocated by Angelita Abagama, and for the complete clinical response, the wait-and-see approach can be an option for all patients. As you can see that the overall survival is not really different, and also the disease-free survival is not significantly different, and we know also that we can treat by salvage TME the patients with local recurrence. So you can see that we have to mix all the problematics to set up the limits of the surgical treatment in oncology, in digestive oncology surgery, the age, and the assessment of priority more than the age, the cancer, the staging, and to avoid the emergency surgery, and to go from optimal surgery to an adapted surgery. For the purpose of this lecture, I wanted to know exactly what were the results for one of the most aggressive surgery we offer to our patients, and the older group of the cytoreductive surgery and HIPEC for patients. And the oldest patients who underwent a HIPEC was more than 75 years old. And during the 15 last years, we operated on 565 patients, and among them 46 were 70 years old and over. Of course, it's a very selected series with AZ241, the performance status good, a good BMI, and the most important factors, the peritoneal carcinomatosis index, relatively low. And you can see that in all the series we have 0.7% mortality, and in this series of 70 years old and over, the mortality was nil. But once again, It's a very selected patient, and all the patients underwent a multidisciplinary decision, a tumor board, including our oncogeriatrician. Here are the curves, survival curves, and it's strictly the same for the seniors and the adults, a little best, but maybe it's more selected. And of course, the most important prognosis factor was the PCI, and when you have a low PCI, you can see the 5-year survival, and the median is not reached yet. So what can be the conclusion? Are there limits? I don't think there are limits, but you have the keys for decision, more than the age, the frailty and the comorbidities, the risk factors for early death after the diagnosis and the surgery, the life expectancy, that is the patient's keys, and the cancer's keys, the stage of cancer, the surgery required, emergency or not, major surgery or not, and of course what we know about the mortality, the morbidity, and the survival rates. And those are the keys for the tumor boards, for the multidisciplinary decision, including many physicians, but including the geriatrician. But behind this, who is who to take the decision and which patient we have to deny? It's really an ethical problem, and I think it's a very, very difficult problem. But with all this and the data we have now, I think that we have all the keys to deliver to the patient and his family a clear and honest information, and those keys has to be faced with the personal and the family project of life and the quality of life the patient is expecting after the surgery. Thank you very much.